nice talks. I hope I will succeed in bringing this together. And thank you for the invitation and in being here. Once I was told you should never be in the position of being between a room full of people and their lunch, so I hope and try to keep you awake. Okay, my conflicts of interest that really do not relate with the present talk. So I was supposed to prepare a case, and this is my case. So we have a 23 years old young lady with no particular past medical history. She's a little bit overweight, admitted in the emergency department with a very strong headache since one day and a very high fever. Her blood pressure is, I would say, rather reasonable, heart rate 80, very high procalcitonin. She's brought to take a CT scan, which is negative. So because of signs of potential meningitis, she undergoes a lumbar puncture, and indeed the rapid test is positive for pneumococcal meningitis. So ceftriaxone is started right away, and the patient is brought to the infectious disease department. Unfortunately, after a few hours, she starts to become less and less responsive. Her Glasgow Coma score drops to, say, 5. And so the anesthesiologist is called, and she undergoes intubation and repeats a CT scan, which is, again, negative. But, of course, she's intubated now. She's admitted to ICU. Blood pressure is still stable, and this is her arterial blood gas on controlled mechanical ventilation with 40% FiO2. I know that there is a mixture of units, so I brought both millimeters of mercury and kilopascals, and I look at millimeters of mercury, and I think this is quite fine. A few hours later, lunchtime, you go back and see the patient with your young resident, and the patient is deeply sedated. She's on volume control ventilation, and though the resident says, well, she started to become hypotensive, now blood pressure is good, but I had to give some fluid. So over the last 6 hours, the fluid balance is rather positive, 2,400 ml positive fluid balance. Tidal volume is 400 ml, respiratory rate 24, PEEP of 5, plateau 23. I am Italian, so I must speak about mechanical ventilation, okay? This is the blood gas she has. 53 PCO2, 99 PaO2, FiO2, 100%. Blood pressure is okay. So, okay, let's go for lunch. Everybody agrees? Shall we go? Someone disagrees? Come on, there's always a colleague that prevents you from going to lunch. They want to treat patients. Okay, let's do what you want to do, and then we go for lunch. What do you want to do? I spoke way too much. What is it that bothers you in this situation? Okay, we gave her some fluid, but, sorry, I didn't bring the number of blood pressure, but let's say blood pressure is fine like before, 115 over 60, heart rate 80, and this is the blood gas. So what would you like to do? 100%, pure oxygen. Anybody? Bjorn?
The driving pressure is too high and the PEEP too low, so I would increase the PEEP to 15, 18.
Basic rule. You should take a ESICM fellowship in Monza at some point, you know. To tell you the truth, I perhaps would do the same. I would be very concerned of that. I'm obsessed with mechanical ventilation, but I just came to this conference and I heard Mauro's very nice talk about the risk of high PCO2 for the brain. And remember, this girl has bacterial meningitis. So if this girl had a pneumococcal pneumonia, I think I would be happy with 53 PCO2, 7.38 pH. But as this girl has a problem in her brain, this is one situation where I don't like permissive hypercapnia. This is a situation, perhaps I would say the only situation, where I think rather than looking at pH, which for 99% of our patients is our target, not PCO2 as far as it is within a reasonable range, our targets starts to become this line below here, PCO2. So, okay, before going for lunch, we fix PCO2 and then we go for lunch, okay? So how can we do that? What would you do?
6 mils per kilo.
What's that?
6 mils per kilo of plasma.
6 ml per kilo. Okay, I didn't tell you. This girl is, you know, Italians like spaghetti, so she's 90 kilos.
90 kilos.
90 kilos. Ah, come on. I didn't say that. So 90 kilos is 6, 6 per 9, 6 times 9. The ideal body weight, the president says. Okay, you spoiled me. She's 175 centimeters, 160 centimeters. Sorry, 170 centimeters. And again, I'm a bit lazy, so I like easy formulas. You can find a complex table on ideal body weight, but I'm very lazy. So for women, you just take the height minus 100, minus 110, sorry, and for men, the height minus 100. So this girl has ideal body weight, to make a long story short, is 60 kilos, and so the tidal volume, 6 ml per kilo, is 360. So here we are already at 7, okay? 7 ml per kilo. What should we do? Increase the rate. I do agree. In this case, again, we are not on the spot of our ideal 6 ml per kilo, but we are still, I would say, in a reasonable range of 6 to 8. So let's increase the rate.
It depends how much.
It depends how much.
And I would also take a look at the ventilator, because, you know, if she has no more time for expiration. And
Yeah.
if I was a neurosurgeon,
That's the problem.
if I was a neurosurgeon, I would tell you the first thing I would do would be an ICP probe now.
But not all the neurosurgeons do agree.
No,
That's the point.
but I think this is a very important point. I didn't put it in the slide, and I was hoping Mauro was here, but unfortunately he doesn't like my talk, so he's pretending he has another talk to give. But when we discussed this case with Mauro said exactly what Bjorn said. So I think we are having a patient who is hypoxemic. We will have a hard time ventilating her. Okay, CT scan is negative, but you know, to have a bedside continuous monitoring of what is going on in the brain of the girl, which is our target now. Okay, I'm a very ARDS guy, but the organ we must save is the brain. Probably having an ICP in place would give us a continuous measurement on the ICP, and perhaps we have the CPP, and so we could tell whether 53 PCO2 is adequate or not. So thank you for bringing this up. This is an excellent point. So I think, okay, we called the neurosurgeon. He's at lunch. Lucky him, and he will come back later to put the ICP. In the meantime, what I would do is increase respiratory rate to 30, keeping IE ratio, let's say 1 to 1.5. We'll discuss about that later on. But I think sometimes we are a little bit scared. If we look at for example, the lung safe data, we are a little bit scared of going too high with respiratory rate, but there's no real reason for, in this case, I think, not increasing respiratory rate. Okay, and then this is what we get. 43 PCO2, 1110 PaO2, I'm reading millimeters of mercury, still on pure oxygen. We haven't changed the other ventilatory settings. So plateau pressure is still the same, which suggests that the patient is not gas trapping because of our increase in respiratory rate. Are we happy with this? Who is happy? Who is quite happy? Who would like to change something? Please, anybody wants to? That's a very good point. That's a very good point. So hyperoxia is rather dangerous. We heard about it. We heard it's not good for the kidney. It's not good for the brain either. So our colleagues suggest to reduce FiO2 to bring PaO2 down below 110. My comment is 110, okay, is slightly above the normal range, but still it's not, I would say, a dramatic value. What concerns me a bit is the fact that we have a patient, sorry, I didn't put the chest X-ray with, let's say, now bilateral infiltrates, okay, so a patient with ARDS, also because this is an ARDS case, that he is still hypoxemic, and okay, now the ARDS is moderate if you want to classify it, but it's very close to be a severe ARDS with an FiO2 of 100 and a PEEP of 5. And to me, this is a little bit of a concern. We are using very high FiO2, and most likely we have the recruitment in the lung that is causing this hypoxemia. The fact that, minute ventilation, just to underline this aspect, is 12 liters per minute, because shunt and dead space are on the same coin. So whenever we have shunt, we have dead space. And so we need to increase minute ventilation because of the increased dead space. This is something we always have to keep in the back of our minds. But also, I would like to stress the fact that while we pay a lot of attention to driving pressure, which indeed, as Bjorn was saying, and Massimo too, is high, 18 driving pressure is high, still, it's worth reminding the dear old compliance, which is an excellent indicator of the size of the lung. And the compliance of this girl is 22 milliliters per centimeters of water. I don't know what would you think about this, but my interpretation in an acute disease is a loss of alveolar units with the recruitment. So I guess I would like to adjust PEEP. And just to go back to the issue of a low PEEP level in patients with severe ARDS, of course I had to have a slide on lung safe, actually I have two. This is what we do in our clinical practice. We are quite liberal in increasing FiO2. You see, this is this is a nice plot done by Tai Pham, and the size of this bar has to do with the number of patients that are on 100% FiO2. So you see, we have many patients on 100% FiO2, many patients on 80% FiO2, and this in yellow is 10 centimeters of water PEEP. This tells us that in our ICU, about 50% of patients who are breathing pure oxygen have a PEEP of 10 centimeters of water or less, which I would say it's quite different than what you would see in the literature data published. The other aspect, as I was mentioning, and this work has been shown many, many times, is the fact that we know driving pressure, so the difference between plateau pressure and PEEP is a very strong, well, I cannot say determinant, but maybe I would say determinant, has a very strong association with outcome. This elegant study by Amato has shown that you can have the same driving plateau pressure, these are groups of patients, you can have the same driving pressure, the same plateau pressure. Our girl has plateau pressure 23. So why bothering for mechanical ventilation in a patient who has 23 plateau pressure? The problem is, it's not just a matter of getting to 23. The problem is, where do you start from? You see that with the same plateau pressure, it's the outcome is very, very different if your driving pressure is high and your patient is more likely to die, or your driving pressure is low, like in this group of patients. So we have a problem here. The driving pressure, I'll skip this, the driving pressure of our patient is high, and also with the lung safe. I was quite surprised to see this, the fact that really driving pressure is a strong number, I would say, was reinforced in my mind when we saw these data. We looked at a completely different setting from what Amato had done, but still we found that a driving pressure higher than 14 centimeters of water is strongly associated with outcome. So we decide to adjust PEEP in these patients. We start from 0 PEEP, just not to be confused. And one approach, what we would do, and then we can discuss about it, is to look at compliance or driving pressure, titrating PEEP. So we start from a PEEP of 0, and our plateau pressure is 18 centimeters of water. Then we increase PEEP by 8 centimeters of water, but plateau pressure increases only by 6. So driving pressure is going down. What does this mean? What's that?
That's good.
That's good. That's good because it means recruitment, okay? The compliance has increased, so the most likely mechanism by which this is occurring is recruitment. And then we keep increasing PEEP, and again, we see that our driving pressure is going down. So we are even more happy. 12 is better than none. And we go on, and now we are on the straight line, on the straight portion of the PV curve. And so we increase PEEP, but driving pressure does not change any longer. Compliance is stable. Again, we increase PEEP to 16 because Mauro Oddo said it's not that bad for the brain, but we see that driving pressure starts to increase again. We are hitting the roof with our head. We are in the non-linear portion of the PV curve. So one option is we decrease tidal volume to keep the driving pressure within a safe range, but we know that we must control PCO2 in these patients. So my final choice would be, and we can debate about that, would be to have a driving pressure of 14 with 12 of PEEP and 26 plateau pressure. It's not the best, but you know, you gotta do what you gotta do. Okay, and then you can also do a PV curve that will basically give you just in one snapshot the view of what's going on in the lungs. But for the sake of time, I will also skip this one. Maybe we can go back to this. And after we optimized PEEP, our tidal volume is 400, respiratory rate is 30, sorry, not 300, it's not HFO. Respiratory rate is 30, PEEP is
Frequency is not fashionable anymore.
exactly. PEEP is 12, plateau pressure is 24. So you see, well, this is a little bit extreme for the sake of clarity, but you can see this kind of phenomena. Maybe the numbers are a little bit exaggerated, but we increased PEEP by 7 centimeters of water, but we are only paying 1 centimeter of water in terms of plateau pressure, okay? So I think I go to my colleague and I say, okay, we achieved recruitment. Now we can go for lunch. And so my colleague says, okay, this was the ABG we had before. Now, if we have recruited the lung, we must see an improvement in oxygenation. And damn, Houston, we have a problem. What shall we do? So there was a talk on the kidney, the talk on the brain, and heart. Perhaps we should look at hemodynamics. What would you do? What I would do, I have no doubt, but I guess I'm the only person in the room, I have no doubt, I would put a PA catheter in.
Can you tell us a bit more what are without the PA catheter, how is she doing with heart rate and blood
Sure. No, sorry. This is something I also wanted to skip. I also will have to skip. This is how she's doing. 95, 55, heart rate 100. She's not passing urines, and CVP is 10.
And did she change from before to this?
Well, the pressure before was 115 systolic blood pressure, and now it's 95. CVP has increased. We increased PEEP, so CVP went up. So I would personally put in a PA catheter. We have a patient has a severe hypoxemia who has an hemodynamic status which is not optimized. And to me, the PA catheter gives you a lot of information, Basically, if I may be a little bit too exaggerated, tells you all you have to know, tells you preload of the left ventricle, tells you cardiac output, central venous saturation, and pulmonary arterial pressure. But I know this is not very widely used. So what else can we do? We can look at pulse pressure variation, and I guess in this situation she will have a pulse pressure variation higher than 20%, most likely, right?
Not necessary.
Not necessary. She might. Let's say she has it.
That is why Swan-Ganz catheter is better.
Needs an echo.
Anyone else?
Needs an echo. Needs an echocardiogram.
Here you are. This is the first time in my life I show an echocardiography at a conference. I swear. First time in my life. So I'm not sure exactly what we're looking at, but my good friend and colleague Fabio Sangalli tells me this is a heart which is contracting very well, but the preload is rather low. Is that correct? Did I pick the right slide? Okay, thank you. We would have done also something simple, again, in the laziness track, which is measure SCVO2. And SCVO2 is low. So it doesn't really matter if the blood pressure, after all, is not bad, because the patient is not passing urines, the SCVO2 is low. So this is not good for the sepsis bundle, but it's not good for gas exchange either. Indeed, the low SVO2 also causes hypoxemia. We have to remind this, that one of the ingredients of arterial saturation is venous saturation. Look at this. We have a low SVO2 because of low cardiac output, low hemoglobin, of whatever reason. It doesn't really matter. If SVO2 is low, this is SVO2 is normal. So imagine we have a 50% shunt, okay? I don't want to make it too complex, but if we have a 50% shunt, so 50% of the blood does not see oxygen, you have blood entering the lung with a saturation of 75%, and this blood will leave the lung with a saturation of 75%. This blood is oxygenated, sees oxygen, leaves the lung with a saturation of 100%. So the average saturation, the final saturation, arterial saturation, is 87, which is not normal, but okay, 87%. If we then change our SVO2, like in our girl, the SVO2 drops because of reduced cardiac output, and we keep the same shunt. Now we are mixing our oxygenated blood, 100%, with a much worse blood, much deoxygenated blood. So at the end of the day, or in your artery, the saturation will be much lower. So I think it's important also to keep in mind that correcting SVO2 is also an excellent mean to correct hypoxemia, if SVO2 is low, of course, which was the case in our curve. So again, thanking Fabio for this nice slide. Whoops. What would you do now? Well, the lunch option is always there, but we have other options. Fluids, pressors. Who would give fluid? Fluids. But fluid balance is 2400 positive. You have a question?
Yeah.
Please.
You've given 2.4 liters of fluids already.
Yes.
She's dropping the blood pressure, and you're concerned about the blood perfusion here. A way to recruit some volume would also be, I don't know if she's already on a vasopressor infusion now, but I would definitely start vasopressor or play a bit with some noradrenaline now on this patient.
Oh.
Because
Thank you. I mean, this was a point I wanted to discuss. I would also personally, well, of course, there are so many numbers missing that it's hard to interpret. But let's say we decided that this patient is definitely fluid dependent. I mean, the ventricle is fluid dependent, okay? So we have two options. One option is giving fluids. The other option is try to bring to the heart the fluids that are already in the body. Albumin. Now that's a Gattinoni stock. I don't want to.
No. It's also my point. I would give albumin together with the vasopressor.
You would give albumin.
Yes.
Anybody has different ideas? Meredith, do you want to step in?
So how about the hemoglobin? So what's the content?
Very good. Very
Yes.
good point. Very good point. Very good point. I think it's also very, very important to
Not anemic, by the way.
to check. No, the number was there, but in our case was not there. But let us assume hemoglobin is above 10.
So transfusion is the option maybe.
It's an option in a young lady.
Ah, okay.
Perhaps in this case, I would try and see if we can increase SpO2 by other means and be a little bit more conservative with
Okay.
with transfusion. That's my view, of
So
course,
how,
because
how about nitrogen oxide? So you can reduce the shunt ratio.
yeah, that's another option. Sorry. Now it's warming up in the last 3 minutes. I know. It's always like that.
But it's a very common problem we have. She's already fluid overloaded, but the intravasal volume is too low, because this is clearly what you see in the echo. I mean, you can give her vasopressors, and you would probably to increase also the CPP if you potentially think it could be beneficial. But she needs intravasal volume, so why not giving colloids, so albumin? Why isn't that an option in this case?
No. I think
mean-
it's an option. I think it's. I personally think no. I just made a joke about the fact that I'm not an expert on albumin myself, but we do use albumin absolutely. We use it also in the resuscitation phase more than in the just stabilization phase. But I think it's important, and I guess it has to do with. It's a little bit like for the lungs. You know where you want to aim. You want to aim to 6 ml per kilo, driving pressure lower than 12, but you need to live with reality. And I guess it's a little bit the same here. We do know that we would like to give fluids to this patient, but we also do know that too much fluid, it's not good for the lung, it's not good for the kidneys either.
So
This-
Giacomo, I think it's also the point that in reality you can do both things at the same
Exactly.
time.
Exactly.
You know.
Exactly. That exactly. So I think and the time is finished, but I think that it's correct. I would have given fluids as well, but I think that simply, putting up there 500 ml crystalloids and say, okay, see you later, it's not what you would have to do. The idea is give at least fluid as you have to give, trying to to monitor what's going on and perhaps help yourself with some vasopressor that could limit, and some albumin that could limit the amount of fluid we are giving overall. So I think the idea is more knowing what your aim is rather than giving fluids or not. What's that? No, so then no way. There's no reason on earth I can skip lunch for. So, okay, we gave fluid and a little bit of norepinephrine, and this is now ABG, our ABG. It's still, I think, quite hypoxemic, but this is the stage where perhaps we could think of reducing FiO2. Normally, I do not, and this is my last comment before conclusion, normally what I do not do is change FiO2 while I do something else, just because you completely lose your readout. If you titrate PEEP and in the meantime change FiO2, forget it. So I think once you have stabilized the patient, hyperoxemia is dangerous, but I don't think like half an hour or two while you stabilize her being on this kind of PaO2 would be really dangerous. And after the situation is stabilized, you can go on and reduce FiO2. Oh, and she's even passing urines. Is this blood pressure enough for a patient with pneumococcal meningitis?
Yeah, about the previous slide, why don't you use the PF ratio instead of keeping the FiO2 at the same level?
Because
isn't that a more trustworthy parameter?
The PF ratio is a very robust parameter if you take it, let's say, in the general population. Every study you do on ARDS, everything, PF ratio is an enormously strong predictor of outcome. If you look at it at an individual patient level, the problem is that PF ratio is affected by FiO2 depending on the amount of true shunt and VQ mismatch. So if you have a patient who has a PF ratio, let's say has a 100 PaO2 on pure oxygen, this does not necessarily mean that the patient has 80 PaO2 on 80% oxygen. So if you want to really assess the gas exchange comparing two PF ratios obtained under two different conditions of FiO2, I think could induce an error. Of course, the number roughly remains the same, but you can make simulations and depending on many factors, including hemoglobin, for example, and oxygen transportation, PF ratio is heavily affected by FiO2. So my suggestion is at an individual patient level, just keep things constant while you are titrating PEEP. Of course, if you then are reassessing the patient the day after, you will have to use the PF ratio to compare the two numbers obtained. For example, and I'll finish, when we assess the gas exchange on our patients on ECMO once a day, and we just set FiO2 to 100, just because it's the only value that you can standardize in every patient. So just a brief period, 10 minutes, to make sure that the value is comparable one day to another. Okay. Just to remind you the issue of acute cor pulmonar, but I think the take-home messages I would like to deliver with these courses, I am sorry to say that, but brain is more important than lungs, so we should do anything we can to preserve the brain. Normally, this is easier for the lungs because for the kidney, because as Dr. Osterman told me yesterday, and I found it an excellent way of making this brief. And what is good for the kidney usually is good for the lung, so they are not competing. And there's no way to manage the patient without a proper monitoring. It's like if you're flying an airplane without windows. There's no way. You have no idea where you're going to. So we have to monitor. Use Van Gans? No, okay. But you have to monitor something that tells you these three things, I think, preload and the effect of mechanical ventilation on preload, cardiac output in absolute terms, and the effect, again, of mechanical ventilation on cardiac output and right ventricular function, and vice versa. These two things are in a circle. Having said that, I thank you very much for your attention.